Today's lecture is on crisis response, suicidality, trauma assessment, and mandated reporting. And I want to just start by talking about the moments that shake us, not the neatly planned sessions, not the calm, reflective processing. I'm talking about the sessions that catch you off guard, the moments when your stomach drops, your breath shortens, your body knows before your brain does that something is not right here. Maybe a client says something vague but alarming. Maybe they show up looking vacant. Maybe they tell you straight out that they want to die. These are the moments where how you respond really matters, where your ability to stay grounded, not perfect, not all knowing, just grounded, can change the course of somebody's life. In this lecture today, we're going to walk through 4 essentials of crisis work. The first being how to respond when a client is in crisis. We'll talk about how to regulate yourself, assess what's really happening, and stabilize the situation without making it worse. Then we'll talk about how to assess and manage suicidality. And this includes the language that you use, the tools that can help, how to assess for risk, and when to involve outside supports like mobile crisis, or if you're in the United States, 988. We're also going to talk about how to conduct trauma-informed assessments. Trauma changes everything, from the way that people tell their story to the way that they sit in your office. We'll explore how to assess without re-traumatizing and how to recognize when trauma might be shaping what you're seeing. And we're also going to talk about what to do when you're a mandated reporter. So you're going to be in situations where you have to report suspected child abuse, elder abuse, or imminent danger of your client or somebody else. And we'll talk about how to do that in a way that's transparent, ethical, and human, not robotic or panicked. From this lecture today, I hope that you're going to walk away with language, tools, and a roadmap. But more than anything, I want you to leave knowing this. You do not have to do crisis work perfectly. You do not have to be an expert in everything. You just have to be present and prepared. Because when things fall apart in somebody's life, what they often remember isn't what you said, it's how you showed up. Were you calm? Did you believe them? Did you listen without rushing to fix? That's what sticks, what keeps people alive. So let's get into it. So let's start with this. A crisis is not just a hard day. It's not just anxiety or sadness or being overwhelmed by school or work. A crisis happens when somebody's usual coping skills stop working and their mental, emotional, or physical safety is at risk. But crisis doesn't always look dramatic. It might show up loud and chaotic, like a client sobbing, pacing, or yelling, or it might be quiet, like a flat affect, a vague comment, or a strange comment after weeks of distress. So in clinical work, crisis might show up as a suicide attempt or somebody saying that they're done but doesn't know how to help keep themselves safe, or panic attacks or dissociation that leave a client unable to function or stay present, or maybe overwhelming grief, rage, or despair that floods their system after a loss or trauma. Maybe even a psychotic break where somebody's hearing voices or losing touch with reality. Crisis could look like an unsafe living situation. Think of Maslow's hierarchy. It could look like returning to an abusive partner, being kicked out, or lacking food or shelter. And it could also look like substance use, which is often the overlooked crisis response. So just jumping on my soapbox real quick, we tend to separate substance use from mental health in systems of care. But in practice, they often travel together. People don't use substances because they're bad or broken. They use them because they're in pain, because it works, at least for a while. Using a substance can be a very natural response to an unnatural situation. It's a way to numb unbearable feelings, to regulate a nervous system in overdrive, or to survive an environment that feels unlivable. So if somebody walks into your office smelling like alcohol or tells you that they relapsed, don't just see the behavior, see the pain underneath, see the crisis. Your role is not to judge or lecture. Your role is to be curious. What does the substance do for them? What are they trying to manage? What's going on in their world that made them feel like using was their best or only option? It's not a quick fix, but it's a powerful shift in how you see your client, and it changes everything about how you respond. So you might ask, what's your role? In crisis, your role isn't to fix it. It's to contain it, stabilize, and connect. So your steps are to stay regulated. You're the grounding point in the storm. If you panic, your client will too. You want to assess for danger. Ask, is this person a danger to themselves, to somebody else? Can they meet their basic needs today? And then offer containment and support. And this means helping the client feel emotionally held and not alone, even if there's no immediate solution to the problem. You want to connect them to help. So that could be a mobile crisis unit, the 988 line in the United States, maybe your supervisor, or maybe one of their family members. We don't want to just refer out. We want to actually connect them. And then we also want to document thoroughly. So describe the behaviors, the quotes, your decision-making, and next steps clearly. Remember, if it wasn't written, it didn't happen. So, I want to just talk about two crisis models that might help you navigate these times. And you don't need to memorize every step, but having a structure to fall back on can help make the moment feel more manageable. So, there's the 6 step crisis intervention model, which I think is a great jumping off point. And then there's also the Roberts 7 stage crisis intervention model that I like just a little bit better because of that extra seventh step that the 6 step doesn't have, and that's the follow up. So the Roberts 7 stage crisis intervention model adds a little bit more detailed, and it's especially helpful in longer or even more acute crises. The first step is to assess lethality and safety. You also want to establish rapport quickly. So be human, be steady, don't over pathologize. You're going to want to identify the presenting problem. What tipped them into crisis? Can explore feelings and emotions, let them vent, stay with them, and then generate and explore alternatives. So, what are their resources? What's worked for them in the past? What are some creative ideas that they can think of to help get them to safety? And then you want to develop an action plan together. So, include formal services, support systems, and personal tools. And that seventh really important step is to follow up. Schedule another contact soon, even if just a call or message. And you want to do that within 48 to 72 hours. So those models aren't recipes, they're just scaffolding. They give you something to hold on to when the ground feels a little shaky for both you and your client. But real life isn't step by step, and clients aren't ever going to arrive in a neat little package labeled step one, define the problem. You don't have to hit every step in order. You don't have to get it right. You just have to show up with intention, with steadiness, and with care. When somebody's in crisis, here's what matters most: prioritize safety. Don't avoid the hard questions. Ask directly about suicide, about violence, about substance use. If you're unsure, consult your supervisor. You also want to offer calm containment. Let your nervous system be the anchor. Your tone, your pace, your presence, they all send a message. And we want that message to be, I can handle this. And you also want to let them know that they're not alone. Whether it's you, a hotline, or a whole team, remind them that there's help. There's a path forward, even if they can't see it right now. Because here's the thing: people in crisis aren't looking for a perfect clinician. They're looking for somebody who will stay with them in the storm, who won't flinch, who won't minimize or disappear. When everything feels out of control, your presence is the intervention. Your clarity is what helps them make sense of chaos. And your connection, the simple act of being with them, can be the first thread that pulls them back towards safety. Let that be your compass when the moment feels too big. You don't need to be brilliant, you just need to be here. So, looking at suicide assessment and management, let's just say it: suicide scares a lot of counselors. We worry that we're going to say the wrong thing. We worry that we'll miss something, that we'll freeze. But the most dangerous thing that you can do in the face of suicidality is to avoid it. Asking somebody directly about suicide does not increase the risk, it does the opposite. It's a moment where somebody finally feels seen, where their pain is named and shared. So when we're looking for assessment, you really need to get specific. It's not a time to tiptoe or sugarcoat. Ask clearly: are you thinking about dying or killing yourself? Do you have a plan? Do you have access to the means to carry it out? How strong is your intent? What stopped you so far? These questions aren't intrusive, they are life saving. You're assessing not just the thoughts, but the intent, capability, and ambivalence. And that ambivalence, that what's stopping you, is often the opening that we need to talk. So you can use models to guide you, you can use assessment tools that give structure, and they are going to help you communicate with supervisors or emergency services, but they don't replace your presence. Some common tools include the Suicide Assessment 5 step evaluation and triage, or the SAFE-T, and the Columbia Suicide Severity Risk Scale, or the C-SSRS. And then there's also the SAD person scale that's really used less in clinical settings now due to limited predictive validity, which you'll learn about in your testing and appraisal course. But the mnemonic can make it really easy to remember if you're struggling to remember the other ones or don't have the SAFE-T or the C-SSRS available to you. So again, these tools are just for scaffolding. They help you organize your judgment, but they don't make the judgment for you. What matters more is how you ask, how you listen, and how ready you are to act. So once you've assessed for risk, you want to interpret the risk. Your clinical judgment here is crucial. Based on the severity and immediacy of risk, here's how you might respond. So if a client is presenting as low risk, that might be suicidal thoughts, but no plan, no intent. You want to support with regular check-ins, develop a collaborative safety plan, and include crisis line info and protective factors. Moderate risk looks like suicidal thoughts with a vague plan or intent and some ambivalence. For this one, you want to increase frequency of contact, consult your supervisor, and explore voluntary higher levels of care if needed. And then high risk would look like maybe the client has a clear plan, access to means, strong intent, or maybe even a recent attempt. Here with high risk, you do not want to leave the client alone. You want to use emergency services, local crisis teams, maybe mobile units, and consider involuntary hospitalization if applicable in your state. And real quick, I just want to talk about safety plans versus no harm contracts. So, no harm contracts are not evidence based. They do not prevent suicide or self harm, and they can create a false sense of security for clinicians. Worse, they often place responsibility on the client to keep themselves alive without providing tools. Safety planning, on the other hand, is collaborative, dynamic, and research supported as an intervention. So the Stanley and Brown model outlines 6 steps. Identify warning signs. So that would be a question like, what are your early signals that you're starting to struggle? Look at internal coping strategies. So you can ask, what can you do on your own to shift your mood? You're going to look at social settings that offer distraction, like where could you go, or who could you be with, or who could you get around to help you get through the moment? You're going to look at people to ask for help. So, who could you call or text when things feel too heavy? You're going to look at professional support. So, that's going to be you as their counselor. And also ask, what mental health or crisis resources can you access? And then you're also going to look at means restriction. So, let's talk about ways to make your environment safer. So, this would be considering regarding means if they have access to pills, guns, knives, weapons, anything. What can they do to create a barrier between themselves and those means? So, this is going to work because safety planning builds collaboration, predictability, and agency. 3 things that are often missing when somebody feels suicidal. It helps anchor them to life in a concrete way. But even the best safety planning isn't a guarantee. Recent studies have shown that safety planning reduces future suicidal behavior, especially when paired with follow up calls or check ins. However, it works best when the client understands and participates in the process. The plan is specific and not generic. Follow up happens quickly, like within 48 to 72 hours. And when the plan is reviewed and updated regularly. Sometimes these safety plans fail, and they're going to fail if the client sees it as a formality or maybe a check the box activity. We're just doing this because we have to. It's going to fail if it's clinician driven instead of collaborative. It's going to fail if the client's access to lethal means isn't discussed. And it's also going to fail if there's no follow up to reinforce the plan. Maybe you spent a whole hour, maybe 75 minutes, maybe 2 or 3 hours creating the safety plan, but if you never check back in on it, what does it really mean? So the takeaway here is not to rush the plan. Don't wing it. Let the client help build it with you. And the goal is they walk away with something that they believe might help, not something that they signed to make you feel better. And then we want to look at trauma-informed assessment. So most clients aren't just walking into your office saying, hi, I'm here because of trauma. They come in with symptoms, trouble sleeping, panic attacks, a sense of emptiness. Sometimes they say, I don't even know what's wrong. I just feel off. Your job isn't to diagnose right away. Your job is to slow down and get curious without prying, pushing, or pathologizing. So think about it like this. Trauma is not what happens to you. Trauma is what happens inside of you as a result of what happens to you. Trauma is about disconnection, especially from the self, from one's body, emotion, memories, or sense of safety in the world. Clients might not remember everything. They might minimize it, joke about it, or not recognize it as trauma at all. And that's okay. You don't need their full story to begin the work. You just need a safe enough space where their nervous system starts telling it. So we're starting with trust. Instead of diving into trauma history, ask questions that invite reflection and control. Ask something like, have there been experiences in your life that still impact you today? What helps you feel safe? What happens in your body when you're overwhelmed or anxious? What's the story your body is telling right now? So let clients opt in. Let them set the pace. And stay attuned to what isn't said too. Silence, freeze responses, or sudden shutdowns are just as telling as words. There's some tools that can help when you're using them gently, like the ACE questionnaire. This is used to explore childhood adversity, but it's never going to be a standalone score. Invite conversation about the patterns, not the points. You can also use interception prompts like, where do you feel that in your body? Does this tightness feel familiar? If that sensation had a voice, what would it say? These questions help clients access trauma stored in the body, especially when they lack words. And you can also look at art-based tools or body maps for clients who can't or maybe won't speak their trauma. Drawing sensations or experiences can bypass the analytical verbal brain and access deeper wisdom. You also might want to consider trauma wearing other masks. So trauma doesn't always present like PTSD. Often it shows up wearing the costume of ADHD with trouble focusing, hypervigilance, and difficulty regulating attention. It might look like mood disorders, emotional flooding, irritability, numbing, maybe personality disorders, especially borderline traits rooted in unstable attachment and fear of abandonment, maybe even some disordered eating patterns. So pause before pathologizing. Ask yourself, what happened to this person instead of what's wrong with them? And that shift changes everything. It centers compassion over correction. And I also want to look at attachment, crisis, and vulnerability. Trauma shapes how people connect or don't connect. Some clients with trauma histories may pull close and then push away, test your reliability, shut down when you get too close, or read neutral situations as threatening. Clients with disorganized attachment may struggle to trust even as they crave connection. Those with avoidant attachment might downplay distress and say they're fine when they're slowly unraveling. And in crisis, these attachment wounds flare up. They might lash out, ghost, or suddenly disclose something massive. When that happens, don't take it personally. See it for what it is, a test of safety, a learned survival strategy. Your job is to stay steady, to remain warm and boundaried, to show with your presence that you don't scare me, I'm still here. Trauma-informed assessment isn't just a checklist, it's a stance. It's the way that you hold space, the way that you notice shifts, and the way that you ask and respond. It's not about naming all the wounds, it's about creating a space where healing becomes possible. And sometimes that starts with a question as simple as, what helps you feel safe with me? So moving on to mandated reporting for legal and ethical considerations, and I just wanted to be really clear. If you're a counselor, you are a mandated reporter. This isn't optional, it's part of the role. It exists to protect people, especially the most vulnerable when they can't protect themselves. But just because it's required doesn't mean it's easy. So depending on your state and your setting, you must report suspected child abuse or neglect, suspected elder or dependent abuse, and imminent risk of harm to self or others. So let's pause there. You don't need proof, you need reasonable suspicion. And that means if something in the session raises a red flag, behavior, disclosure, or physical evidence, you don't wait until you're sure. You act on what a reasonable person in your position would suspect. It's not your job to investigate, it's your job to report. So when a disclosure happens, here's what you do. This moment can be tense. Clients might shut down, panic, or get angry, but your role is to be clear, calm, and kind. So here's what to do. You want to pause the session, stop the clinical work, and shift into mandated reporter mode. Explain your duty. Use language like, because of what you've just shared, I'm required by law to make a report to keep you or others safe. And I want you to understand every step that I take. And then ideally, you're going to make the report with the client present. If possible, include them in all parts of the process. It models transparency and minimizes rupture. Then you're going to want to notify your supervisor. Always consult. If it's after hours, follow your agency protocol. And finally, document everything. Include direct quotes, behavioral observations, your decision-making, and who you notified. This process might feel like a betrayal of trust, but it doesn't have to be. When done with care, it can model safety, consistency, and protection, especially for clients who've never experienced that before. And just talking about some state-specific processes. So in Pennsylvania, for example, involuntary commitment is known as a 302, and it's a formal legal process. You must show that somebody possesses a clear and present danger for themselves or others, and you submit documentation to an approved delegate or county mental health office. In other states, there may be less formality. You might call a mobile crisis unit or police directly to initiate emergency services. Some counties have dedicated crisis lines with mental health teams who can respond to you in person. So you want to know the law where you practice. Even across state lines, the difference can be massive. And you want to remember that reporting doesn't have to be cold or punitive. In fact, how matters just as much as the what. So a few tips are to stay regulated. If you seem panicked or rigid, your client will too. You want to be honest and compassionate. You can say something like, I don't want to hurt our relationship and I care about your safety. This is a step that I am required to take to protect you or somebody else. And then validate the disclosure. It was brave to tell me that. I know the next part might feel hard. And stay with them through it. Don't make the report and then move on like nothing happened. Talk about what support they need next. Talk about how they're feeling. Talk about the relationship. And this is especially important for clients with trauma histories. Mandated reporting can echo past experiences of having control taken away, being punished for speaking up, or being betrayed by adults. Your presence and attunement matter. Mandated reporting is part of our job, but it doesn't have to define your relationship with the client. It's a tool for protection, not a weapon, not a punishment, not something to fear or avoid. And while the law is very clear, every situation is going to bring nuance. So consider the client who's 17 and pregnant, or the adult survivor who names an abuser still living in the home, or the teen who discloses self-harm but begs you not to tell their parents. That's why consultation is essential. Don't go it alone. Because when it comes to protecting others, it's not just about making the call. It's about how you hold that moment with clarity, courage, and care. Now, the last part of this lecture, I want to talk about counselor self-care after crisis work, because this part doesn't really get put in the textbooks. what it means to walk out of a session holding somebody else's terror, grief, or shame in your chest, to sit in your car after a hard day at work, wondering if you did enough, or to crawl into bed at night still feeling their pain echo in your nervous system. This work can be beautiful and unbearable, sometimes in the same hour, sometimes in the same minute. And the truth is that people most drawn to helping are the ones who are most vulnerable to burning out. You're trained to attune to others, to hold space, to lean in, but that skill, the very thing that makes you good at what you do, also makes you more likely to carry emotional residue after sessions. So let's talk about how to carry it without letting it bury you. You're going to want to know the signs of impact. Trauma doesn't just affect clients, it affects clinicians too. It's called vicarious trauma. So, how to know when it shows up? You're going to want to look for emotional exhaustion and irritability, trouble sleeping or shutting off your brain, feeling numb, detached, or cynical, second guessing yourself constantly, or avoidance of certain clients or topics. These aren't flaws, they're flags. They tell you that you've been running too long without rest. So, when we look at self care practices that actually help, we're going to want to go beyond bubble baths and surface level self care like manicures. The research supports deeper practices that sustain counselors over time. And it's going to start with reflective supervision and peer consultation, not just to debrief, but to metabolize what you're holding. Supervision isn't just for skill, it's for your soul. It gives language to what feels unspeakable. You can also look at using creative expression. Make art, write a poem, keep a visual journal. Research shows that creative self expression can help counselors process secondary trauma and reconnect with their purpose. You're going to also want to think about intentional rituals for transition. So, ending your workday with a closing ritual like washing your hands, saying a prayer, lighting a candle, stretching. Your nervous system needs cues that it's safe to come back to baseline. Maybe it's listening to the same song on your commute from work to home. I also highly recommend using a box for your wins. This is something that my supervisor taught me. So save all your notes from clients, your doodles, your thank you messages, maybe write down your light bulb or aha moments. Any gifts that clients give you, put them in a box. On the days when you wonder if you're cut out for this, on the really hard days, let that box remind you that you matter to somebody, that you can do this job and you can do it well. You can also look at moving your body in kind ways. Trauma lodges itself in the body, not just in the mind. Walking, dancing, yoga, whatever helps you come back to yourself. Even a 10-minute walk outside can help you regulate your nervous system and reset your day. You're also going to want to get your own therapy, even if things feel fine, especially if they don't. If you work with trauma, you need somebody to help you hold what accumulates. And finally, you're going to want to connect with people who see you beyond your role. Friends, family, animals, music, anything that reminds you of who you are outside of being a counselor. It's not your only identity. Your worth isn't measured by how well you hold everyone else together. Your gift is your presence, not your perfection. Some days your best will be brilliant. Other days your best will just be showing up, tired but trying. Both matter. And when you feel like you're unraveling, remember this. It doesn't mean you're weak. It doesn't mean you're not meant for this work. It means you're human, a human doing very hard, very sacred things. So care for yourself like you'd care for your favorite client, gently, persistently, with compassion and boundaries. You don't have to be fearless. You just have to be whole enough to keep showing up. So in summary, you're going to face crisis. Maybe not this week, maybe not this semester, but it's coming. And when it does, it will not wait for you to feel confident. It'll likely show up in the moments when you feel very unconfident. It'll show up mid-session, on a Friday afternoon, in a voicemail, in a sentence that knocks the wind out of you. So ask yourself right now, do I know what steps to take? Do I know how to stay calm when somebody else can't? Do I know how to protect both my client and myself? This isn't about being perfect. You won't always say the right thing. You might feel awkward. You might freeze for a second. That's okay. What matters is that you're willing to stay present, willing to feel the discomfort, willing to take action even when you're scared. And remember that you are not alone. Your preparation matters, your mindset matters, your heart matters. So no, you don't have to be fearless, but you do need to be ready. And now you are.